engaging clients who use substance. And I would like to introduce to you today's presenters. Natasha Elkelman is a registered social worker who has been working in the field of geriatrics for 10 years. She came to BSO from the Alzheimer's Society, Waterloo, Wellington, where she ran support groups, provided counseling, and worked with memory clinics and geriatric teams. For the past 6 years, she has been working in the role of BSO Transitional Lead and loves the fact that this role offers support in community that transitions with the clients into long-term care and for 6 weeks post-admission. Outside of the work, she is a busy mom to her 3-year-old identical twin girls and is often seen singing and dancing everywhere she goes. Oh boy, you're a busy lady, Natasha. Congratulations on the twins. I would also like to introduce to you Catherine Peaver. Catherine is a registered social worker who has been working with individuals living with dementia and their families for the last 8 years. Prior to working the field of geriatrics, Catherine began her career in child welfare. Catherine enjoys working alongside community service providers to enhance their skills to promote patient-centered care. She has provided transitional support to clients and their families, navigating long-term care in Hamilton, Brantford, and Norfolk. Outside of work, Catherine can usually be found taking care of her flower gardens and spending time with her husband and their 2 teenagers. You're busy too. Thank you so much, Natasha and Catherine, for being here and for all your expertise. We're really excited for your presentation, and I am going to hand it over to you now.
Okay. So I just want to say hello, everyone, and thank you to all those who are tuning in today to listen to our presentation. We're going to be talking about a few things, but we wanted to acknowledge who else is on the call with us today.
So we also have our extended support team. We have Lenore Noel and Brooklyn Dennis and Manny Pekowski. They are part of our management team and have been invaluable as we have prepared for this presentation. So we just wanted to give a little bit of a shout out to our team that we know is watching live as well.
So today we'll be talking about how we have utilized a best practice guideline to enhance our program. We're going to start by reviewing who we are and what our program is about. Sorry, I'm seeing if my slides are working, but I don't think. Oh, there we go. So yes, this is our overview. We're going to, we will outline our BPSO journey and how we chose our best practice guideline. We're going to review our gap analysis and how we implemented our best practice guideline. We'll touch base on some knowledge transfer and exchange we were able to engage in. And we'll end our presentation with some of our lessons learned, our next steps, and obviously opportunity to ask us some questions.
All right, so what is Behavioural Supports Ontario? Behavioural Supports Ontario is a provincial initiative that was created to enhance healthcare services for older adults in Ontario that are living with complex and responsive behaviors associated with their dementia, mental health, substance use, or other neurological conditions. The initiative also provides enhanced family caregiver support in the community, in long-term care, or wherever the patient resides. So our region encompasses Haldimand, Norfolk, Hamilton, Burlington, Niagara, and Brantford. We have a very wide catchment area, and our BSO program supports over 80 long-term care homes in these regions. I wanted to just spend a little bit of time at the beginning to give an overview of what our program looks like. We have a program that is unique, I believe, to our area. Our BSO program is broken down into 3 different subparts. Our mobile team is comprised of a clinical coach that is an RPN and a care support worker who is a PSW. Our mobile team receives 2 different kinds of referrals for transitional support and for episodic support. Transition support is provided during a resident's first 6 weeks living in a long-term care home. The clinical coach and care support worker observe and interact with the resident in different settings. We want to see how they're eating, if they're making social connections, if they have been receptive to allowing care support, and just overall how they are adjusting from living in their previous environment to the big changes that come along with a move into long-term care. If the mobile team notes that there are some bumps in the transition, they work together with the resident, their care team, and the resident's family to smoothen out those bumps over the transition period. The other type of support is episodic. This is initiated by the long-term care homes when they identify that a resident is having expansive expressions that negatively impact them or those around them. The staff use a person-centered BSO intake tool to better understand the behavior that is occurring, and then they look to identify triggers that could be contributing to this behavior. The team then trials strategies with the resident based on the identified reason for referral. Once we have a feel that these strategies are the right ones, we would model them to the staff at the long-term care home. So our BSO mobile team works alongside staff members in the long-term care home to build their capacity related to the needs of their residents. At the end of the modeling, our team shares a summary of successful recommendations prior to discharge from our program. We also have our social workers. They receive referrals to provide support to individuals that are capable of engaging in social work support. They may provide counseling support using a strength-based modality, and may also provide support related to specific tasks, such as connecting individuals to other programs. So a little bit about our, next slide, please. Yep. Thank you. A little bit about our Transitional Lead program. So our Transitional Lead program was funded in 2017 to support patients and their caregivers through the long-term care referral and transition process. The program assists clients that have exhibited one or more responsive expressions that are seen as deterrents to long-term care admissions. The Transitional Lead provides information and proactive engagement with clients. We create a BSO transitional care plan that is shared with the long-term care home that resident would be moving into. The TL program was created to help bridge the gap between community and long-term care. So who do we serve? The program initially did not support individuals who were using substances. We've had changes to our program since its initial conception, and now we accept part of the program. We've widened our criteria, and that now includes referrals for individuals that use substances.
And just to touch on that, we actually did that as a response to meet the BSO provincial mandate, because it does include meeting the needs of individuals who may use substances.
Thank you.
You're welcome.
So we get our referrals through Ontario Health at Home. We work alongside the placement coordinator. They are the ones that determine whether a referral would be appropriate. Our criteria is we are looking to support individuals that have an expected bed move anywhere from 4 weeks to 6 months of us receiving the referral. When we receive the referral, the first thing that we want to do is obtain consent from our substitute decision maker or power of attorney for the client that we are supporting. Sometimes we do support residents that are capable of making those shelter decisions themselves, and we would obtain consent from them directly. We would go out and do a home visit in the community at their place of living. That may be a group home, a retirement home, or someone's family home. We complete screeners. We are screening for pain, depression, and delirium within our first interaction or two with the residents that we will be working with. We use an intake tool based on the PIECES model to help us identify what the reason for referral is. And really the biggest thing is what's changed, that now that that they are seeking out support, as much information related to the behavior and events surrounding it as we can. We do follow-up visits and we complete necessary assessments based on the screeners. If we have identified that someone may be at risk for depression, we are following it up with comprehensive assessments that will be shared with their care team. We will try, similar to the mobile team, different strategies of engagement and related to the reason for referral. We create a care plan that would go out to the different long-term care homes. And then when they do move, we help with that transition. So we would work with the resident and their families and the staff at the long-term care home for approximately 6 weeks. And we work along the mobile team to make sure that the transition is as smooth as we can help it to be.
So this is a little bit about our BPSO journey with BSO.
We started in 2020 and we have come a very far way since then, and it's been really neat to be able to see the changes over the last 5 years. We have implemented several best practice guidelines. We have focused on person and family-centered care, assessment and management of pain, delirium, and dementia in older adults, and assessment and care. I just wanted to bring light to the second column. There's a tree. It's probably quite small on your screen. This is our tree of change. So it really identifies why we feel that we are champions of change. And it outlines some different words that we felt captured our leadership and the transformation that our team has gone through and how we've best been able to support the residents that we serve. In 2024 and 2025, we initiated the Healthy Work Environment, so professional and leadership best practice guideline, and we are engaging in the best practice guideline of residents who use substances. Our next one coming up in the future is for 2025-2026. We're going to be looking at the best practice guideline of transitions in care. So how did we decide this best practice guideline? In 2023, the leadership and community of practice identified a need for education on mental health and addictions. We recognized that there was a gap in our BSO program and around substance use. Part of our provincial mandate is to work with individuals who use substances. Our focus has primarily been on dementia care, so we've been working to broaden our scope to meet the criteria of the provincial mandate. In 2024, with the support of our BPSO coach, Ulrike Lamel-Joseph, we engaged in a gap analysis and identified the gaps with regards to substance use. We reviewed each of the RNAO's best practice guideline recommendations related to engaging clients who use substances. Through this exercise, we found some gaps. The first one being lack of education really around substance use. Our lack of knowledge regarding what's out there. If we've identified that someone would like to connect with services, what are the services? And we, at the time, didn't gather information specific to substance use. What information that, and we want to know the information that we're collecting, how does that translate into the work that we do? So how are we able to incorporate that in a transitional care plan that identifies goals that match what the client is looking to do? So we started with a gap analysis, and our team met several times to develop some screening questions. The initial questions that we developed were trialed and reviewed with the team. We got back together to discuss how that went. Through discussion, we identified the wording of our questions at the beginning it was quite a mouthful to get out, and we really didn't feel that this was the best standardized question to use with the residents that we're supporting. We edited the questions to ensure that they were direct and easier to understand. Once the questions were redeveloped, we went out and we tried them again. And we have come to a consensus of the right of the questions that we feel are meeting the needs of our program right now.
And meeting the BPG recommendations 1.1 and 1.2. So what we came up with was, have you ever had any problems related to your use of alcohol, cigarettes, or cannabis? And has someone in your life been concerned about your drinking, smoking, or use of cannabis, or suggested cutting down? Those are the questions we've implemented into our intake tool, and we ask every single person.
So 5.2, healthcare providers to participate in continuing education to enhance their ability to assess and work with clients at risk or experiencing a substance use disorder. So in 2023, we had 2 different occasions that we were all able to come together for in-service education. We received training through a psychiatrist and concurrent outpatient medical psychosocial addiction support clinician, that's a mouthful, Dr. Tanya Hawk. And in addition to this in-service, we also received education and training from a concurrent disorders outreach worker, Kate Rizzuto. In fall 2024, we had the opportunity for Kate to come and present to us again. And this was just with our Transitional Lead team. We learned about different ways to speak with older adults about substance and alcohol use. We learned about normal signs of aging versus signs of alcohol and substance use. We continue to screen. If the screener is positive, we assess need and adapt to whatever the wishes our clients have.
Right. So some examples from the education that we received is just around the language that we're using and how we're engaging our clients in discussion around this. So for example, maybe instead of saying, do you drink? Are you a drinker? We're going to say, hey, you know what? Lots of people enjoy a glass of wine or a mixed drink on occasion. Do you ever drink anything with alcohol in it? And if yes, what do you like to drink? How often do you like to drink that? Keeping it very casual. And reducing the stigma, right? Or instead of saying, I'm worried you might be an alcoholic, we're saying, I'm concerned that alcohol is maybe causing some problems for you. Or you shouldn't drink when you're on medication. Instead of saying that, maybe we're saying, you know what, lots of medications can interact with alcohol in some potentially harmful ways. So I'm concerned about you taking this medication when you're drinking. So just kind of really just trying to destigmatize it and open up the door to conversation about it in a respectful way. Some of the harm reduction strategies, for example, just working with older adults who may be using alcohol that we received in our education and training was ideas like spacing out drinks every 2 hours, for example, or working with caregivers and giving ideas like, hey, you know what, maybe we're going to disable the stove or the oven and encourage the use of a microwave instead. Some caregivers, like spouses, for example, they're looking for ways to kind of help reduce some of the alcohol intake. So maybe it's, let's water down some of those beverages, or have you tried near beer as an option? So these are just some ideas that we've incorporated, and the education that we received really helped give us the tools to have these ideas in these conversations. The last recommendation that we implemented was 6.1, and that was advocate for improved health outcomes. So the way that we kind of do that is by, again, it's based on client wishes. We're connecting them with a worker in the community. We're really much focused on more of like a harm reduction lens. So, for example, switching to non-alcoholic beverages like near beer. We're informing clients of some options for things like nicotine patches, there's smoking cessation programs. We're talking to the long-term care homes and reminding them they can partner with like the program STOP to provide the residents with up to 26 weeks of no-cost nicotine replacement therapy. And that is an option that is also available in community for those who are on the wait list for long-term care. We engaged in knowledge transfer and exchange in a really fun way. So as you can see, there's a picture of Catherine and I in our makeshift Charter for Change bus. So we were able to, in January of this year, we did an interactive presentation to our whole HNHB BSO team. We described our charter for change. And how we did this was we physically had a bus and we picked up each of our teammates. And every time we picked up a teammate, they talked about things that we have implemented in order to create some change in our program. So for example, one of our teammates spoke about the changes we made to identify gaps. Another talked about how we used BPGs to come up with questions around substance use. And then we picked up another one of our teammates, and they talked about how we engage in dialogue with people who are using substance use. There may have been some car karaoke along the way. There was definitely dancing when I'm involved. So and with caregivers, we started to have discussions around ways that we can limit or reduce substance use if that is the goal. And then with our external partners, so Catherine mentioned we develop BSO transitional care plans. And so if this comes up, we talk about it in our care plan. That care plan is given back to Ontario Health at Home, and the long-term care homes that our clients are on the waitlist for have access to that. Sustainability. Don't we love this word? I sure do. So in order to make things sustainable, we really have to make sure that's happening at a policy level in our program. And one of the ways that we're doing that, like I said, in our screeners, every single intake, every interaction we have with every single client, we're asking those questions about substance use. So we're opening that discussion with every single person. We're also collecting that information at discharge. It's going into our discharge summaries. We're screening for substance use and number of persons at risk for or who experience a substance use disorder. We also did an evaluation with our team. So in May of this year, a questionnaire was sent out just to ask the TLs about their experience since implementing the best practice guidelines. And then we made sure our team is aware of the resources in their community. So there's wonderful resources already listed. If you go on RGP Central, Specialized Geriatric Services, Central Ontario, or Health Services for Hamilton under the HNHB Healthline.ca, great resources, don't need to reinvent the wheel, it's all there for us. And our work doesn't stop there. In order to be sustainable, we have to complete yearly reviews, and we're committed to that. So we'll continue the process of doing needs assessments, gap analysis, and update the program as needed. These were just samples of our evaluation. So if you really look into it, basically what you're seeing is that everything's working well. We're really happy with the questions that we're using, and there's no problems or barriers that we're experiencing when we're talking about these things with our clients. And then last, our lessons learned. So what did the TLs like about this process? We liked that we got to be a part of it, and we got to be a part of it right from the beginning. We liked that we received education that was helpful and hands-on with concrete examples. We got to share our experience in a fun and interactive way with our colleagues. What were the challenges? We got a little bit late on doing that evaluation, but we did do it, so it's done. Initially, we weren't sure about what to do once a client identified that they do use substances. We weren't sure what to do with that information. The education has helped us with those discussions and navigating the next steps with clients. And initially, we weren't aware of resources in the community, but now we are. And what did we learn? New ways of asking about substance use, an understanding of what supports are in our communities, and how knowledge can be translated in a way that supports our clients transitioning from community to long-term care. So, and that's our roadmap. Catherine already talked about it. As you can see, we are we just finished a gap analysis for spring 2025. We're deepening deeper into that gap analysis right now. We're looking at implementation for around fall, winter 2025 for transitions in care. So that's exciting stuff. And this is our lovely transitional lead team in our Charter for Change bus. So that's our presentation. If you guys have questions, we're here, we're open.
Wow. Just amazing. Thank you so much, Catherine and Natasha. Thank you so much for sharing more about engaging clients who use substance and your approach to supporting them. I really do love the Charter for Change bus. I think that's amazing.